Hello, my name is Isabel Lusada, and I'm the CEO and President of the Amyloidosis Research Consortium, or ARC. ARC is a nonprofit organization whose mission is to accelerate the development of and access to new and innovative treatments and improve quality of life for all patients with amyloidosis. Welcome to ARC Talks. The ARC's webinar series is focused on improving diagnosis and care of amyloidosis patients. With the approval of the first treatments for ATTR amyloidosis, it has never been more important to quickly and accurately diagnose and treat patients with these progressive diseases. To address this, today's webinar is about PYP imaging for diagnosing transthyretin cardiac amyloidosis. The use of PYP has revolutionized non-invasive diagnosis of ATTR amyloidosis, but it's critical to understand the proper use and limitations of this tool to improve diagnosis. Our presenters today are leading experts from the amyloidosis field, Dr. Maurer and Dr. Bokhari from Columbia University. In this talk, they'll be covering the PYP diagnostic process from patient selection to scan protocol and interpreting the results. I'll now hand off to Dr. Mathew Maurer, a medical director of the HCM Center at New York Presbyterian Hospital, Columbia University Medical Center, a general internist and geriatric cardiologist with advanced training in heart failure and cardiac transplantation. He is a leading expert in cardiac amyloidosis. Thank you.
Here are our disclosures, both for Dr. Bukhari and myself. So today, at the end of this webinar, we hope you'll be able to identify patients with transthyretin cardiac amyloidosis who may benefit from PYP scintigraphy, understand the indications and contraindications to technetium pyrophosphate cardiac scintigraphy performed in the US, and the non-invasive pathway for evaluating patients with suspected transthyretin cardiac amyloidosis, and in particular to be able to highlight causes of a false negative and false positive PYP scan. And use best practices, that is, and enumerate best practices that have been delineated for the performance of PYP testing using appropriate grading techniques, both a quantitative and semi-quantitative, interpret scintigraphy in the clinical context, and be able to identify any incidental findings, and understand the appropriate reporting nomenclature to be communicated in a technetium pyrophosphate scan report. So, as background, unfortunately, misdiagnosis and delayed diagnosis of cardiac amyloidosis is a commonplace, not a rarity. As these data highlight, presented by Isabel Lusada at the Amyloid Research Consortium, of patients who are diagnosed with cardiac amyloidosis, about 75% had to see, unfortunately, 3 physicians before a diagnosis was made. And more than 60%, it took more than 6 months to make a diagnosis. And unfortunately, many, they received an incorrect diagnosis initially. I don't think it's bad that individuals had to travel to establish a diagnosis. And the most common diagnoses that were made, particularly by cardiologists, as a misdiagnosis were either hypertensive heart disease or hypertrophic cardiomyopathy. So there's great room for improvement, and we hope PYP scanning will assist in an earlier diagnosis. In general, I would just say that in order to make a diagnosis of cardiac amyloidosis, you must think of it in your differential. If you don't think about it, you will never diagnose it. In the past, endomyocardial biopsy, as you're well aware, was the standard technique to diagnose cardiac amyloidosis, somewhat invasive and restricted to specialized centers, though clearly having a very high sensitivity and specificity. Endomyocardial biopsy, as we'll talk about today, has been replaced by non-invasive nuclear scintigraphy. These are data accredited to Claudio Rapezzi in Bologna, who really rebrought this technique back to the forefront, notable in this publication in JACC in 2005 in a small series of patients in which they did DPD scintigraphy. DPD is the bone scintigraphy isotope used in Europe. They did whole body scans, and as you can see in the patient in panel A and B, there was no uptake in the myocardium, whereas in panel C and D, you can clearly see there is uptake in the myocardium indicative of transthyretin amyloidosis, which on SPECT scanning shown at the bottom is clearly evident. And so heart retention of the isotope was much higher in those with TTR amyloid versus AL versus controls, and in fact, In this small study, it was 100% sensitive and 100% specific. We believe that pyrophosphate scanning, particularly in the US, can facilitate an early diagnosis of cardiac amyloidosis. Obviously, endomyocardial biopsy, the gold standard, is, as we mentioned, limited to really specialized centers that are able to perform this. That's typically cardiac transplant programs, whereas pyrophosphate scanning can be available in almost every cardiology practice who has a nuclear camera, which by ACC estimates are almost 10,000 practices in the US. So much wider application for earlier diagnosis, leveraging scintigraphy than endomyocardial biopsy. Additionally, right heart catheterization, as you're aware, is performed at the time of an endomyocardial biopsy. There's costs associated with its performance in addition to the biopsy, and then downstream pathological interpretation also requires significant expertise. The gold standard for pathological interpretation is a laser dissection mass spectroscopy, which is usually available at few centers such as the Mayo Clinic. Cost for all of those tests together is estimated to be about $5,400, whereas scintigraphy is quite cheap. The cost of the isotopes in the range of $30, and based on whether you do a plain or a SPECT scan, current reimbursements are in the range shown here, several $100s. So clearly, potentially a more cost-effective way as well. In our data at our center, we've shifted over based on recent consensus documents to use scintigraphy for non-invasive diagnosis, and these are just preliminary data showing in 126 patients diagnosed by PYP scanning with transthyretin amyloid versus those with endomyocardial biopsy. We identify patients with an earlier phenotype. Their median New York Heart Class is 2 compared to 3. They have low voltage but greater voltage when diagnosed by PYP, slightly higher blood pressures, lower BNPs, higher ejection fractions, less wall thickness, and lower LV mass. And all of this, again, would suggest that PYP can enable an earlier diagnosis, which is key to several emerging therapeutic drugs. Additionally, while PYP doesn't improve survival directly, it is associated because of this increase in early diagnosis with improved survival in the patients that I just showed, which also is, I think, critically important. Survival in patients with cardiac amyloid, all forms, is dependent upon the degree of amyloid involvement in the organ that's most affected, in this case, the heart. And again, PYP enables an earlier diagnosis. So here are some clinical scenarios that should raise a suspicion in your mind of cardiac amyloidosis. And again, a heightened index of suspicion is key. Obviously, patients have an increase in wall thickness without an obvious cause, such as hypertension and or aortic stenosis, for example. Heart failure in the setting of preserved ejection fraction, particularly when there's concomitant right heart failure, as evidenced by JVP, hepatomegaly, and lower extremity edema. The classic finding of discordance between the increase in wall thickness and the EKG voltage. So it's not just looking for low voltage, but integrating the voltage and the wall thickness. Orthopedic manifestations are common, including carpal tunnel syndrome, lumbar spinal stenosis, or spontaneous biceps tendon rupture, should raise a suspicion. Paradoxically, low flow, low gradient aortic stenosis, that is aortic stenosis in the setting of a low gradient but with a preserved ejection fraction, the paradox being the EF is not low, as is in the classic low flow, low gradient AS. Diffuse delayed enhancement or increased extracellular volume seen on a cardiac MRI, in which the MR is highly suggestive of amyloid. Apical preservation on speckle strain echo is strongly suggestive of amyloid, also can be seen in other disorders, particularly chronic kidney disease and hypertension. Natriuretic peptides are often elevated out of proportion to the clinical syndrome in patients with cardiac amyloid, and many patients with amyloid-associated myocardial apoptosis have persistently positive low-grade troponins without a clinical acute coronary syndrome. So all of these should raise suspicion. If you're thinking about performing the test, again, these are individuals who, according to the ASNC practice points, American Society of Nuclear Cardiology, are appropriate for PYP imaging. Again, individuals with heart failure and unexplained increased wall thickness, particularly African Americans over the age of 60, because they carry a mutation in the TTR gene called the VAL122 ILE mutation that's prevalent in 3.4% at birth and leads to late onset transthyretin amyloidosis. Individuals, again, who are over 60 with unexplained heart failure in the setting of preserved EF, reiterating the importance of these orthopedic manifestations, including particularly bilateral carpal tunnel syndrome, anyone with unexplained neuropathy in the setting of cardiomyopathy, or atrial arrhythmias in the absence of usual risk factors or symptoms of heart failure. Evaluation of cardiac amyloidosis can also be performed with PYP imaging in individuals who have either known or suspected familial amyloidosis, so they're relatives, for example, of a proband, and individuals with either a cardiac MR or echo that's consistent with amyloid. Certainly, PYP imaging would often be the next best test. And patients with suspected transthyretin and contraindications to MR, such as those who have indwelling pacemakers, defibrillators, or renal insufficiency. So a large population that could be evaluated for this emerging test. To review, systemic amyloidosis is characterized by an extracellular deposition of a fibrillar protein. That protein deposits in the organ and interferes with its structure and function. Today we're focused on the heart. While there are more than 24 proteins known to form amyloid fibrils in vivo, in patients who have cardiac amyloidosis, there are essentially 2 proteins that predominantly affect almost all the individuals, more than 95%, and that is AlAmyloid associated with a plasma cell dyscrasia, and transthyretin amyloidosis that's associated with either wild type or non-mutant TTR, what we used to call senile cardiac amyloid, or TTR that carries a mutation or variant form, which we call ATTR-H or ATTR-V for variant or hereditary disease. The distinguishing features for the various types of amyloid are shown here. AlAmyloid is a disorder of the light chains. It is not diagnosed with scintigraphy. The average age of the patients is 55, with a wide range, is generally equal males and females, and cardiac involvement occurs in about a third of patients, though increases over time with the duration of the disease. A fat pad biopsy is a reasonable test in AlAmyloid, whereas you can see its yield in transthyretin, be it hereditary or mutant form, is and or wild type is quite poor. Most patients with AL are seen initially by a cardiologist, nephrologist, or hematologist, and as you're well aware, AlAmyloid is a systemic disease associated with many extracardiac manifestations, including nephrotic syndrome, autonomic dysfunction, periorbital purpura, and a big tongue are seen in AL, but not in transthyretin amyloidosis. Most importantly, AL is a highly malignant disease that, if misdiagnosed in the setting of heart failure, can lead to a patient's demise in a very short period of time, which distinguishes, as you can see in this table, from transthyretin, though, which has a more benign prognosis. Wild-type TTR in the final column is predominantly a disease to date of older adult males, and cardiologists are the main providers, whereas hereditary TTR obviously affects individuals at a younger age than wild type, given its genetic nature, and cardiac involvement is variable depending upon the mutation, with both heart and nerve involvement often in these individuals. So again, it's important to remind everyone that AlAmyloid, really cardiac AL, is a medical emergency. It's a disease that's associated in the setting of heart failure with high morbidity and mortality. And so we like to encourage providers, if they're considering AlAmyloid, to give yourself no more than a week to get the answer. That is, bring the patient in and we'll explain the series of blood tests that we would recommend for evaluation in all patients with cardiac amyloid, but particularly for AL, to exclude it as a cause. These are classic echocardiograms of various patients. Here's a patient with HCM, as you can see, a patient with hypertension and renal failure, lysosomal storage disease, and in the upper right, amyloidosis. So none of these are easily distinguishable by echocardiography. Echo really serves to raise the suspicion for the diagnosis, but can never confirm either the type of amyloid or the presence of cardiac amyloidosis. There are essentially 6 routine blood tests to obtain on any patient who you suspect of cardiac amyloid, 3 that are used to assess for the monoclonal protein, one of which is an assessment of actually urine, and 3 that are used in various staging systems. So in order to rule out AlAmyloid, you need to assess for monoclonal proteins by a kappa lambda free light chain, a serum immunofixation, and a urine immunofixation. not just an SPEP, but serum and urine immunofixation, telling the laboratory you're looking for small proteins. And then there are biomarkers, including NT-proBNP, troponin, and renal function that have been used in various staging systems, which are shown below. The panel all the way to the left is the AL staging system that relies on NT-proBNP, troponin, and the difference in the free light chains, shown by the Mayo Clinic. In the middle is the wild-type TTR cardiac amyloid staging system published by the Mayo that involves NT-proBNP and troponin, and to the right is the National Amyloid Center in London's staging system that involves NT-proBNP and EGFR. These can identify patients who have early, middle, or late disease. Most importantly, if individuals have evidence of a monoclonal protein, it's essential for you to consult with a hematologist, because such individuals have the substrate for AlAmyloid, and in that setting, scintigraphy is not 100% specific as a diagnostic test, and I will review that shortly. So we recommend referral to hematology and their engagement in individuals who have evidence of monoclonal proteins. We should point out, however, that since a majority of patients with transthyretin amyloidosis are older adults, the most common thing you'll see besides just transthyretin amyloid by itself is transthyretin amyloid with a monoclonal gammopathy of unknown significance. And so again, engagement in hematology and careful interpretation of the monoclonal proteins is important. And as I mentioned previously, when tissue is being typed, we like to rely on mass spectroscopy when there's any doubt, because immunohistochemistry or IHC has been shown to lead to discrepant and incorrect attribution of the precursor protein. The serum free light chain shown here is a revolutionary assay which allows us to assess for monoclonal kappa or lambda light chains that are being produced by a plasma cell dyscrasia. The intact immunoglobulin is shown to the left, and the dissociated extra kappa and lambda free light chains. These are not only diagnostic of the substrate for the disease, they're prognostic, as I mentioned, in the Mayo staging system, but they are the target for anti-plasma cell therapy in managing patients with light chain amyloid. So a pretty revolutionary test. As shown in this diagram here, you do not want to be ordering a serum protein electrophoresis, but rather you want to order serum immunofixation. And when coupled with a kappa lambda free light chain ratio, the two serum tests have a 99% sensitivity for identifying the substrate for AlAmyloid. So incredibly important. In general, for patients with AlAmyloid, they cannot be diagnosed again with scintigraphy. The only way to diagnose them is with a biopsy. General practice is to biopsy the most involved organ. Obviously, abdominal fat pad is easily accessible and is a reasonable first test. But if your clinical suspicion is high and a fat pad is negative, given its sensitivity, you need to go on to, again, and biopsy the involved organ. Bone marrow biopsies rarely show amyloid, though they can obviously elucidate the plasma cell dyscrasia. And the clinically involved organ, in this case the heart, is nearly 100% sensitive and specific. Shown to the right are two scans that are being circulated, and you can see one to the left does not have any cardiac uptake, and one to the right does. These are examples of PYP scintigraphy, and so if a monoclonal protein is absent, is not present on initial screening, and you do have availability, hopefully, of bone scintigraphy, you can establish a non-invasive diagnosis of transthyretin cardiac amyloidosis with either PYP, DPD, or HMDP isotopes. If the scan is positive, as Dr. Bukhari will elucidate, that is strongly suggestive of cardiac amyloid, and again has a specificity as reported and amyloid centers of 100%, and if it's negative amyloidosis, transthyretin is quite unlikely, because again these individuals already did not have a monoclonal protein. If bone scintigraphy is not available, you can certainly call a center such as ours or others to obtain a scintigraphy, or you could proceed on to more invasive testing, traditionally with a biopsy. Dr. Bukhari at our center led the charge here with this seminal paper in 2013, in which he leveraged a PYP, an isotope similar to what Dr. Rapezzi utilized in Bologna in 2005, but much more common and approved by the FDA in the US. And these are examples of two patients, the upper panel of a patient who has a negative scan in which uptake is in the sternum in red, and a patient on the bottom who has uptake obviously in the myocardium. I usually joke and say that I am not a nuclear cardiologist, nor do I need to be one to interpret these scans, which is clearly demonstrable of increased myocardial uptake. And Dr. Bukhari will review later, but he created the heart to contralateral ratio, a semi-quantitative method in which when the cut point was above 1.5 in this initial study, it was 97% sensitive and 100% specific for identifying transthyretin cardiac amyloidosis, be it from wild type or hereditary disease. So these data and others from multiple other centers under the leadership of Julian Gilmore in London led to this seminal publication in 2016, in which a consensus document suggests that in patients who have a clinical phenotype that suggests amyloid, a CMR, or an echo that's suggestive, if you perform bone scintigraphy with any of the three agents, and there was no uptake or grade 0, amyloidosis is unlikely. Grade 1 patients can have either AL or TTR, and further testing is required. But in individuals who had no evidence of a monoclonal protein, so serum IFE, urine IFE is negative, and a kappa lambda free light chain ratio is normal, and had grade 2 or 3 uptake, you could establish the diagnosis of transthyretin amyloidosis, and then go on to genotyping to figure out if they had variant or wild type disease. The data emerging from that paper are shown here, in which you can see the sensitivity and specificity overall, and we'll discuss this further. But again, one of the more common reasons for a false positive scan is AlAmyloid. So PYP scanning is got a reasonable sensitivity and specificity up front. But as you can see from the final column here, when coupled grade 2 or 3 uptake scan, with no evidence of monoclonal proteins, we have achieved a level of specificity of 100%, essentially one that can replace the performance of an endomyocardial biopsy. Additional data that were collected in the States, just evaluating PYP specifically, were published in JAMA Cardiology from both Boston University, Columbia, and the Mayo Clinic. And as you can see here, the area under the curve, or AUC, was quite high with excellent sensitivity and specificities. So a very useful test. Again, I want to highlight the consensus document. So you should see a phenotype that you think is consistent with amyloid. Nowadays, that's usually a cardiac MR or an echocardiogram more commonly that is consistent or suggestive of amyloid, increased wall thickness, maybe a speckled pattern, apical sparing, diastolic dysfunction, increased in intra-atrial septal thickening, all of those suggestions, preserved apical strain. And then when you subject the patient to scintigraphy, they have grade 2 or 3 uptake, that is uptake equal to or greater than the bone. And most importantly, they do not have evidence of a monoclonal protein. You cannot interpret PYP scanning in the absence of an assessment for monoclonal proteins. And that's one of the more important messages we want to impart today to people doing this test. Please don't order scintigraphy without assessing for light chain amyloid, because you can't be 100% sure it's transthyretin, and we will misdiagnose many patients without appropriate use of the test. Unfortunately, we've collected some data to suggest this is not being done, hence one of the bases for the webinar today. In Amyloid Center at Columbia, everyone gets an assessment of monoclonal proteins, but when clinicians are leveraging PYP scanning, we reported this a few years ago, almost a quarter did not obtain assessments of monoclonal proteins, and so the scans really cannot be adequately interpreted. So it's emerging now that scintigraphy, shown down here close to a biopsy, is a early marker of TTR amyloid. Uptake occurs in patients actually intriguingly even before at times the wall thickens or they develop significant diastolic dysfunction. And so in the cascade of amyloid in which we're trying to identify people earlier, we can move from where we used to be with low voltage or symptoms or echocardiographic findings down the amyloid cascade to identify people much earlier with scintigraphy. Accordingly, we believe it has a significant clinical value, and hence the reason we're emphasizing it here today. We'll go into greater detail, but scintigraphy is not a perfect test, and so there are false positives I mentioned. Most commonly are the first two, that is AlAmyloid can be excluded by assessment of light chains or blood pooling, and then a focal uptake can occur in the setting of either a previous MI, rib fractures, God forbid metastatic lesions because it's a bone isotope. There are reports of an APOA1 mutation, particularly seen in Italy, causing uptake, which is not really a false positive for amyloid in general, but not for TTR. And there's reports of plaquenil toxicity causing a false positive. On the false negatives, there's, we'll highlight this in cases, patients who have TTR mutations that result predominantly in full-length fibrils. They don't have uptake on scintigraphy, and so there are false negatives, obviously, if the disease is relatively early, or if you delay imaging for a long period of time, you can get a false negative. And as shown in all the little red asterisks, many of these can be addressed with SPECT imaging, which is emerging as an essential part of PYP scintigraphy. So I'm going to now turn the next portion of the webinar over to my colleague, Dr. Bukhari, who's been instrumental in developing this technique, operationalizing, and then bringing it to clinical care. So it's my pleasure. Sabi, take it away.
Thank you very much, Matt, for the kind introduction. And thank you for inviting me to do this. I'm going to talk about nuclear imaging modalities. So there are two types of modalities which are available. One is a SPECT modality. The other one is a PET modality. These are two different cameras or two different methods of imaging. And SPECT is about close to 10,000 sites have cardiac SPECT imaging available in US. And there are about less than 400 sites in US which have capability of doing cardiac PET imaging. So there are different tracers which are available to do amyloid imaging. One is bone-seeking tracers. And the bone-seeking tracers, if you look at this slide, the top three are the SPECT tracers. PYP is done in US, and now also in a lot of other countries, including China and Asian countries have started doing PYP imaging. And also some of the European countries are doing PYP imaging now. And the other one, which is HMDP or MDP, is also technetium labeled, and this is also a SPECT imaging agent. And the third one, which is widely used in Europe, is DPD imaging, which is also technetium labeled, and these are all three SPECT imaging agents. And they are clinically mature as compared to PET tracers. The only PET tracer which is a bone-seeking tracer is sodium fluoride, fluorine 18 labeled sodium fluoride. Now, all these bone-seeking tracers can diagnose TTR, cardiac amyloid, and there's no uptake in AL or control patients of these bone-seeking tracers. So the other tracers which are available are MIBG, which is a sympathetic neurotransmitter radionuclide analog. And this is approved for heart failure patient and is used for prognostic value of MIBG in heart failure patients. And this is used in patients who have TTR with FAP. Its specificity is low because it can be abnormal. The uptake can be abnormal in patients with heart failure, with ventricular arrhythmias. So, but it's useful and can diagnose FAP, especially TTR with FAP in early stages. Then the other one is amyloid deposits, and that amyloid deposits are seen with PET tracers with fluor beta pair and fluor beta pan, and they are used to detect beta amyloid plaques in brain for Alzheimer's patients. They also can diagnose amyloidosis, but would be at you won't be able to differentiate between AL and TTR with that. Looks at amyloid deposits. These are relatively expensive tests compared to SPECT imaging. The isotope itself costs around $1,600, and the PET also imaging is more expensive than SPECT imaging. So the whole test costs anywhere from $3,000 to $4,000 compared to SPECT, which is in hundreds of dollars. So let's go to the next slide. So in Europe, they use DPD scans, and they have been using it since 2005. This is basically looking at whole body imaging, which is quite different than what we use over here. In Europe, they inject the patient, wait for about 5 minutes, do a whole body scan for about 25 minutes, and then wait close to 2.5 to 3 hours, and then repeat the whole body scan, and then do the SPECT imaging. So the patient is in the lab for close to 4 hours. And also the imaging time for the patient lying under the camera with the arms up is over an hour. Most of the imaging, nuclear imaging, which is done in Europe, is done at the hospitals and is run by nuclear medicine physicians. And on the contrary, in US, most of the nuclear cardiology imaging is done by cardiologists, and most of it is done as an outpatient test. So DPD is not available in the United States. So when the study was published by Rapizzi's group, Dr. Maurer had asked me to see if we could do DPD over here. But DPD, because it's not approved in US, so we looked at other tracers which were similar in chemical structure to DPD. And the one which we found was closest was PYP. And PYP was readily available in US and approved for the following conditions. It was approved for bone imaging, which is widely used in US for bone imaging, and also for blood pool imaging for GI bleed, and also for MAGA studies, gated blood pool studies. And it was also approved in late 70s and early 80s for detection of acute myocardial infarction. So when we did some literature search on PYP, we found some case reports from early 80s, which were like single case reports suggesting that this might be an agent for diagnosing cardiac amyloid. But then there was a case series published which said that this was useless because the sensitivity and specificity was quite poor. But mind you, at that time, they were not able to adequately distinguish AL and TTR. And that was prior to use of endomyocardial biopsy and mass spectroscopy, and prior to light chain assay. So based on that, we decided to develop a protocol for PYP imaging, but our goals were to have a simple protocol, which can easily be performed as an outpatient setting. And it has to be a low-cost study. And instead of having the nuclear cardiologist decide what dose to give, we wanted a standard dosing, so everyone gets the same dose. And also we wanted a shorter protocol, not the patient doesn't have to stay in the center for about 4 hours. And also less radiation for the patients and easy image interpretation. And also we did not want the whole body scan, because if you do the whole body scan, then you need a nuclear medicine physician to read that. So for cardiologists, we just wanted the imaging for the heart. So we developed this protocol in which, if you look at the bottom row, that's the protocol which we developed. So we injected the isotope PYP, about 10 millicurie, and then we imaged the patient after an hour. If the planar scan is positive, patient has the imaging time of 3 minutes. And if the planar scan is negative, patient is under the camera for 6 minutes. And then if we need to do a SPECT, it's another 10 minutes on top of that. So the whole imaging time is less than 20 minutes. And it's a pretty simple protocol. There are no specific test preparation is required, no dietary restriction. Patient doesn't have to even take off their clothes for the imaging. And it's a pretty simple test. And there are really no contraindications for this test, except patients who have claustrophobia cannot go under the camera, but these are open cameras. These are not like MRI cameras. Or a patient is unable to lie flat for about 10 minutes. Or if the patient has poor IV access and you can't inject PYP. Or if patient has had any history of allergic reaction to PYP. We have done close to 1,000 studies, but I have not had single test which was canceled because of any contraindication. So these are the, this is a little busy slide, but I'll show you on the left side were the protocol which we started with. We started with 30 millicurie, then gradually decreased it to 25 millicurie, 20 millicurie, 15, and then 10 millicurie. And then we started imaging at different times from 4 hours to 1 hour, and compared all these images to look at the quality and look at the counts. And then what we did was we acquired just one set of image. We kept the collimators at 90 degrees so we can get the anterior view and lateral view at the same time. And those are the two views required for interpretation of the studies. And also what we did was we acquired the images at total counts of 750,000 or 2 million counts for all the patients and see which ones were better. And then on the right side, you can see the final protocol now, which is being followed by most of the sites, and also has been recommended by American Society of Nuclear Cardiology practice points. So in this, you can see no fasting required. These are rest scan, and the dose has been gradually decreased to 10 millicuries. And time to acquisition, which is preferred, is 1 hour. And also the counts with which you get the best images required is 750,000 counts. So this right side is this protocol is being followed. So if anyone who wants to start the imaging, I would suggest to look at this protocol. Then I'll go over the how we interpret the study. So the first thing we look at is study quality. If you look at the left side of the image, on the left side, the first image is the anterior view, and the second image is the lateral view. So the quality of the study we look at is whether there's any uptake in the sternum and the ribs. This is a bone-seeking tracer. If you don't see any uptake in the sternum or the ribs, that means the study quality is poor and you cannot interpret the study for amyloidosis. The second thing we look at is if there's any myocardial uptake. So in this case, you can see the left images where you're seeing the anterior view and the lateral view. You don't see any uptake in the heart. So you know there's no uptake in the heart. And then what we do is we give a visual score. If there's no uptake in the heart, it's 0. And then the visual score 1 is if the uptake is less than ribs. And this is read on the lateral view. If there's any uptake in the heart, we look at the lateral view because lateral view separates the sternum from the myocardium. So you can see it much clearer, the uptake in the myocardium. Then you look at the intercostal space and see if the uptake in the myocardium is equal to ribs, less than ribs, or greater than ribs, and give a score of 1, 2, 3. 1 is less than ribs, 2 is equal to ribs, and 3 is greater than ribs. And if the score is greater than, in this first image, the score is 0. And the second image, which is important thing, is when there is myocardial uptake, we look at the pattern of uptake. If the uptake is focal or diffuse. In amyloidosis, you only get diffuse uptake. You do not get focal uptake. If there is focal uptake, that's usually an old MI, or if there's a rib fracture in that area, or sometimes in constrictive pericarditis, you can see some. But remember, if there's no diffuse uptake, it's highly unlikely that this is TTR cardiac amyloidosis. Then what we do is we look at, in this image on the right, you can see there's a central clearing, and then there's myocardial uptake. So if you have a patient like that, and you can easily see the uptake in the LV and the RV, patient like that, is positive for TTR. The visual score is 3. So visual score of 2 or greater is considered positive for TTR. And so in these patients, once you have central clearing and myocardial uptake, you're done basically. You say that there's no TTR. You don't even need SPECT imaging for these patients. Same thing with 0, patient score of 0 or 3, you're done with your test and you know whether the patient has TTR or does not have TTR cardiac amyloidosis. These are some examples. So the first image on the left is a control patient. You can see no myocardial uptake on the lateral and anterior view. and the heart to contralateral ratio is 1, visual score is 0. The second patient is AL patient, the second image, where you see mild uptick in the myocardium. And on the lateral view, you can see the visual score is less than ribs. The uptake is less than rib, and visual score is 1. And heart to contralateral ratio is 1.13. The third one is TTR mutant type, which was V122I mutation in this patient. And here the score, visual score is 2, equal to ribs, and heart to contralateral ratio is 1.52. So this is positive for TTR. So the cutoff for heart to contralateral ratio is 1.5, and for visual score, the cutoff is 2 or greater. And then the visual score of the last image, the final image, shows the visual score of 3. This is the TTR with wild type, and heart to contralateral ratio of 2.06. And this is positive for TTR cardiac amyloidosis. So your first image and the last image, in which the visual score is 0, heart to contralateral ratio, and the last image, where the final image, where the visual score is 3 and heart to contralateral ratio is 2. These patients, you are done. You don't need a SPECT for these patients. So these patients, you know, this is positive or negative for TTR cardiac amyloidosis. But patients who have a score of 1 and 2 are the ones who are borderline patients. So in some of these, you'll see a larger breast, or have a lot of soft tissue, or have pericardial effusion, or sometimes pleural effusion large. In those patients, it's sometimes hard to look at myocardial uptake and draw your heart to contralateral ratio in those patients. So in those patients, we rely on transaxial SPECT image. And we look at the myocardial uptake and rib uptake on the transaxial slices and give a visual score on transaxial SPECT slices. So anyone who has some attenuation in the myocardial region, you should rely on SPECT visual scoring. For heart to contralateral ratio, to have some quantitative data. So first we look at if it's diffuse or not. Second, we look at visual score. Then we look at some quantitative score with the heart to contralateral. So we draw our ROI over the left myocardium, over the LV, and then mirror image copy it on the contralateral side, and look at the mean counts per pixel for the heart, and then on the contralateral side, and get a ratio. So ratio of 1.5 or greater suggests TTR cardiac amyloidosis. And on these numbers, where you can see the top one are the mean pixel counts, and the second row on the right, or in the middle, is the max counts, and then the total counts, but we follow mean counts per pixel. So whenever you're doing that, I think the biggest problem which a lot of sites have is either they start following max counts or the total counts. We need to follow mean counts per pixel, which gives you the best sensitivity and specificity for the test. Other thing which is very important on, these are different examples which I'm showing you for the same patient. So this patient is how they draw the heart to contralateral ratio. It only takes a minute to draw the heart to contralateral ratio. So what I suggest to the physicians in our lab, the nuclear cardiologists who are reading it, is to draw it themselves. Or you can have a very well-trained technologist who can do that. But the things which are important is you have to make sure that your ROI, which you're drawing for the LV, is away from the sternum. Otherwise, your counts would be off. On the left, you can see it's including a little bit of the sternum, your ROI, and your counts, your heart to contralateral ratio is going to be significantly higher than what is supposed to be. On the contralateral ROI, it has to be away from the RV and has to be above the diaphragm. Otherwise, you'll have either high or low heart to contralateral ratio based on that. And the last figure you see is it has to be in the chest wall. Have few patients who, if it's off the chest wall or if it's below the diaphragm, you'll have falsely high or elevated heart to contralateral ratio. So very important where the regions are drawn. Then we do SPECT, and SPECT is helpful. Again, it avoids overlaps of bone uptake, and also if there's attenuation, it helps with visual assessment. And also it assesses the distribution of myocardial PYP uptake, and it also helps in distinguishing blood pool activity from myocardial activity. And also looking at quantity or quantify the degree of myocardial uptake by comparison to rib uptake. the value of PYP SPECT imaging with CZT cameras need further validation. So there are some sites who have this new cameras, which are CZT cameras called SPECT CZT cameras. And those cameras are able to do planar imaging. So you cannot get a visual score. You cannot get the heart to contralateral ratio. The only thing you can do is a SPECT scan. So there have been a couple of studies, but it's not there yet. So there are a few examples. So this is a patient who, if you look at the top images, with image after 1 hour, you see there's mild uptick on the left upper image, mild uptick in the myocardium, same thing on the lateral wall. You can see the visual score is about 1. Heart to contralateral ratio is 1.5. So, and if you look at the SPECT imaging, we can see the blood pool. So the area which you see a white thick line in the middle, that's the sternum. And on the right of that is LV and RV blood pool. So we know it's blood pool. So we wait for an hour, we repeat the scan. That will be 2-hour incubation. And at that time, you see it clears up completely, the myocardial uptick, and heart to contralateral ratio is down, and your SPECT does not show any blood pool. So it's important that if you have a visual score of 1 or 2, to do SPECT imaging to make sure it's not all blood pool. And if there is blood pool, you repeat the scan after another hour of incubation and see if the score has gone down or if the blood pools still persists. And then with the SPECT imaging, we can also look at the distribution of PYP uptake in patients with TTR cardiac amyloidosis. It's important, we are collecting the data, but the significance of this distribution, was the, whether it would be important in serial imaging and quantifying uptake. This work still needs to be done on that. These are a few examples of wild type and AL cardiac amyloidosis. So if you can look at the wild type, you can see significant myocardial uptake, no uptake in the AL cardiac amyloidosis. And same in anterior view, lateral view, and then when we look at the heart to contralateral ratio, it's greater than 1.5 in wild type ATTR patient, and none in the AL cardiac amyloidosis patient. So most of your studies, close to 70% of the studies would be either positive or completely negative. So those 30% of the studies which would be borderline, for which you have to look at SPECT scans. Now in this one, the top one is V122I mutation. Again, you can see the heart to contralateral ratio is 1.9 and visual score is 3 in this, and there's diffuse uptake in the LV and RV on both. And then on SPECT scans, you can see that there's myocardial uptake in both. So this is just some preliminary data from Columbia. It was about 6 months ago. We had done close to 685 patients. In that, about 225 patients had SPECT imaging done. So about 40% of the patient had a visual score of 0, and another about 20% or so had a visual score of 1, and then 6% had a visual score of 2, and another approximately 30% had visual score of 3. So about total of 60% patients by a visual score only were negative, and 40% were positive for PYP imaging. Then we looked at about 100 patients who had planar and SPECT scans analyzed. So we found the ones who had 0 score had no blood pool. The ones who had a score of 3 had no blood pool. So blood pool was present in score of 1 and 2. And among those patients, 56% of the patient who had a visual score of 1 and 2 had blood pool on their scans. So it's important, again, patients with score of 1 and 2 get a SPECT imaging. So when we interpret the images, there are a few things which we look at, which we should look at on all the scans. Is always look at anterior and lateral planar images. And if you're doing the SPECT imaging, look at the rotating images and also the SPECT images to see if the regional distribution and if the uptake is in the myocardium or blood pool. Then we look at the image quality first on the scan, whether there was any uptake in the ribs or sternum. and then look at visual scan interpretation by looking at if the uptake is diffuse, focal, or focal and diffuse, and then look at visual score, and then look at heart to contralateral ratio, and then SPECT findings if the SPECT is done, and then look at incidental findings. So in about 10 years ago, oh no, not 10 years, I think about 6-7 years ago, we did a serial imaging study. And in this study, we had a very small number of patients. We had 20 patients total. 10 were wild type and 10 were mutant. And out of those, 8 were V122I and 2 were ALA60 mutation. And we repeated the scan about 1.5 years later in these patients. And only 2 were getting TTR stabilizer, and none of the other patients were getting treated for TTR cardiac amyloidosis, except they were getting their other treatment for heart failure. And we found no significant difference between the baseline and follow-up imaging in these patients. But they were all, to start with, had grade 3 visual score and had a heart to contralateral ratio, which was higher. So they were not early disease patients. So in reporting, it's important that we include the demographics of the patient and also why the patient was sent. And if the patient has had any prior imaging procedures, including echo and MR, and what were the findings on that. And if the patient has had any biopsy, fat pad biopsy or endomyocardial biopsy, the results of that. And also the procedure, what type of imaging technique was used, and how much radiation dose was given to the patient, and what was the interval between injection and scan. That's very important because the 1.5 cutoff works if the period was about an hour. And if we increase it to 3 hours, then the cutoff is not 1.5. Then we use a cutoff of 1.3. So it's important that you know what the interval was between injection and scan. And also the scan technique, whether patient had only planar imaging or also had planar and SPECT imaging. For reporting, same thing when we are doing interpretation, it's 6 things which we look at: image quality, visual scan, whether it's diffuse or focal uptake, then visual score, then heart to contralateral ratio quantitative, then SPECT finding, and then the incidental findings, if there are any incidental findings. It's important that when we conclude a report to conclude it with this statement that if your heart to contralateral ratio is less than 1.2 and visual score is 0, you can say that scans are not suggestive of TTR cardiac amyloidosis. But if your visual score is 2 or 3 with heart to contralateral ratio of greater than 1.5, you know that there is no blood pool in the patient by seeing negative SPECT for blood pool. In that, you write this, that the scans are strongly suggestive of TTR cardiac amyloidosis. But patients who have a visual score of 1 or 2 with blood pool, or their heart to contralateral ratio is between 1.2 to 1.5 are equivocal studies. In those studies, it's important to write that these could represent AL or early TTR cardiac amyloidosis. So interpret the results in context of prior evaluation. But again, if you have echo and MR, which are strongly positive, and your PYP imaging is negative, consider certain mutations in which you can have a negative PYP, and also in early disease, you can have a negative PYP imaging. The other important question is for billing. For planar with SPECT imaging, the CPT code is 78803. Now, this is not specific for amyloidosis. This billing code is used for radiopharmaceutical localization of tumor or distribution of radiopharmaceutical agent. And do not use this 78803 code if you're not doing SPECT imaging. If you're doing planar imaging alone, then you use 78800. And this SPECT imaging code cannot be used if you only do SPECT. It has to be planar with SPECT. So then it's 78803. Otherwise, only planar scanning is 78800. And you always use the isotope code with that, which is 9538 for PYP imaging. American Society of Nuclear Cardiology has excellent practice point, which were recently updated a few months back, and in which they go in detail over overview, background, patient selection, obtaining the radio tracer, imaging procedures, imaging interpretation, reporting, and billing. So take-home points, PYP imaging can enable a diagnosis of TTR cardiac amyloidosis without biopsy if there is no evidence of monoclonal protein. And planar evidence of PYP uptake should be supplemented by SPECT imaging to define if there is myocardial retention or for some other reason, blood pool, rib fracture, or MI, which has focal uptake, which would represent a false positive scan. And clinical suspicion is key to early diagnosis.
So again, thanks, Sabi, for that excellent discussion. And I think to round things out, during the webinar, we're going to present a few cases in tag team. So we have a few cases to highlight some of the major important points. So here's case one. I'll turn it over to Dr. Bokhari. He can run through it.
So case one, 77-year-old male with history of surgical bioprosthetic AVR 2015 and progressive dyspnea is and bioprosthetic valve appears normal with normal gradients. However, the myocardium appears thickened and there is trace pericardial effusion. Past medical history, severe AS, status post bioprosthetic AVR 2015, and history of carpal tunnel release in 2002. His labs shows SPAP, immunofixation, no abnormal clone, kappa, lambda normal, and ratio normal, and normal troponin T. Troponin T was 0.9 and NT-proBNP was 2,200. So should a PYP scan be performed? A is yes, endomyocardial biopsy can sometimes be incorrect. B is yes, a PYP scan can confirm ATTR cardiac amyloidosis. If positive, a biopsy is not needed because he tests negative for an abnormal protein. C is no, diagnosis must be confirmed by endomyocardial biopsy. And D is no, the next diagnostic test should be.
Yeah, and so people think about it, but the correct answer is B. You can confirm TTR cardiac amyloid in this setting. This individual may have, as we mentioned before, gradient AS in the past. One of the orthopedic manifestations of TTR amyloid, that is carpal tunnel release in the past, and has no evidence of monoclonal protein by serological testing. And so if a scan is done, it's positive. He would meet the non-biopsy diagnostic criteria for TTR amyloid. So here, this individual's scans are shown, Sabi, maybe you just want to walk us through what we see here.
So the first scan is the anterior view, and we can see the sternal uptake, not that clearly the ribs uptake. So the scan quality, I would say, is good, not excellent. But there's significant myocardial uptake in here. So, and then when we look at the lateral image, which is in the middle, and these are both planar images. On the lateral image, we see the uptake in the myocardium is greater than ribs. So we'll give it a visual score of 3. And then we draw the ROI on the anterior view. So remember, the heart to contralateral ratio is done in the anterior view, and on the lateral view, we do the visual scoring. And then on the last image is the SPECT image, where we can see clearly the myocardial uptake in the myocardium, and there's no blood pool. So this one is positive for TTR cardiac amyloid.
Yeah, I'd also probably point out with my arrow here that you can see there's even, it looks like in this excellent SPECT image, RV uptake in the free wall. So you can almost make out like a 4-chamber view or 2-chamber view, clearly a positive in the myocardium. And to your point, here was the heart to contralateral ratio. Visual score you mentioned was about 2, and HCL here 1.85. So as you implied, the interpretation here would be diffuse enhancement with a visual score of 2, the HCL ratio 1.83, that's strongly suggestive of TTR cardiac amyloid. And in the absence of an abnormal monoclonal protein, it's essentially diagnostic of transthyretin amyloidosis. So pretty straightforward. Sabi, maybe comment on the data that you collected along with Dr. Castano about patients with significant AS undergoing TAVR and the prevalence of cardiac amyloid?
Right, so the data which Adam Castano collected, and so about 16% of patients who were going for TAVR were positive for ATTR cardiac amyloidosis by PYP imaging. And if we look at male and female, 22 were males and 4% were females who were positive for TTR cardiac amyloidosis with PYP imaging.
Yeah, pretty impressive. And it turns out that in other series, it's estimated about 1 in 7 patients undergoing aortic valve replacement, either surgically or with a transcatheter approach, has a concomitant amyloidosis, so not rare. Excellent case. Case number 2. Again, Sabi, I'll let you start with case number 2.
So this is a 70-year-old female whose brother died of ATTR cardiac amyloidosis, V122I, and she was found to be positive for V122I mutation. And she was asymptomatic, her fat PET biopsy, her transthoracic echo, and cardiac biomarkers are all normal. This is her scan, which was done in 2016, and the visual score was 0, and heart to contralateral ratio was 1.14. So how would you read her PYP scan? No myocardial enhancement, visual score 0, heart to contralateral ratio 1.14. So the conclusion for A is scan rules out ATTR cardiac amyloidosis. And for B, the conclusion is scan not suggestive of ATTR cardiac amyloidosis.
What's the right answer here, Sabi?
The right answer would be B, because the scans are not suggestive of ATTR cardiac amyloidosis.
Right, with a positive, allele carrier of a mutation, suspicion should remain relatively high despite the negative testing, and you wouldn't want to conclude that it's never present. So we'll go on with this case. I guess it sounds like doing routine follow-up. She's noted to have atrial fibrillation, and so some concerns for maybe the phenotype progressing. So the first scan was in 2016, and this is the subsequent scan in 2017. And Sabi, I'll turn it over to you for interpretation.
So if we look at myocardium and compare the myocardium you see in 2016 and then you see in 2017, slightly more uptake in here. So, and when we looked at the visual score on this was 1, and when we draw the heart to contralateral ratio, it was 1.2. So it has increased visual score from 0 to 1, and heart to contralateral ratio has increased from 1.14 to 1.2. Again, still it's by the data which we have is not diagnostic for a TTR cardiac amyloidosis, because the cutoff which is used is 1.5, and visual score of 2 or greater is used to diagnose TTR cardiac amyloidosis. But still there's a progression. So in this case, progress from 0 to 1.
And this might be a good place if someone did it for SPECT imaging, would you say, at this point with grade 1 uptake? Or
it would be helpful to see with grade 1 uptake that is it blood pool or myocardial uptake. So in this case, it has now gone from visual score of 1 to 2, and heart to contralateral ratio has increased from 1.2 to 1.53. So now, by definition, it's positive for TTR cardiac amyloid with a visual score of 2 or greater and heart to contralateral ratio of 1.5 or greater. So in 2 years, it has gone from visual score of 0 to visual score of 2.
Yeah, and this is a good example of what people are beginning to do without, I'd say, hard data, but that is trying to identify the earliest cardiac effect of TTR and allele carriers of mutation by doing serial PYP scanning. Obviously, we don't know how frequently to scan individuals, though the radiation risk is, in my opinion, pretty low. And obviously, since PYP becomes positive often before the walls thicken, the biomarkers go up, and since the drugs work early, this is potentially an emerging area for PYP scintigraphy, that is to scan individuals who are allele carriers to find them as early as possible, institute therapy, and ameliorate the phenotype. Case number 3, I'll start. It's a 65-year-old who's got hypertension, diabetes, obesity, and obstructive sleep apnea, lower extremity edema, and renal dysfunction. EKG shows normal sinus rhythm. There's a troponin I and NT-proBNP are normal. So highly unlikely, to be honest, to be cardiac amyloid, though not impossible. TTE is a normal with an EF that is shows, transthyretin echo shows DF, mildly increased wall thickness. Light chains, SPEP immunofix, and UPEP immunofixation are all negative. And here's a scan. I don't see the ROIs here, but I imagine the ROIs. Let me just see. Oh, there they are drawn over the heart and over the contralateral, but there's obviously a hot spot in the right chest. Sabi, do you want to comment about that?
Sure. So in this age group, when you're looking for TTR in the patients who are older age group, you might see some rib fractures, and the rib fractures would look exactly what you're seeing on this picture. There'll be increased focal uptake of PYP. And also you want to make sure that it's not a neoplastic lesion. It's not a MET. So you want to make sure, so in patients like that, where it's, there's just a single rib uptake, it will be advisable to do a bone scan, dedicated bone scan, to rule out if it's not a neoplastic lesion. But when we are drawing the ROI on these patients, it's important to make sure we don't include this region in the ROI, because that would a false heart to contralateral ratio. So in these patients, what we would do is we draw a small ROI on the contralateral area first, and avoiding the focal uptake, and then mirror image copy that and put it on the myocardium, and then get the heart to contralateral ratio.
I think you see that here in the next slide, where the ROI has been redrawn, as you mentioned, made a little bit smaller and excluded that hot spot. Now we have an HCl ratio that's not below 1, but 1.13. And I'll let you interpret the chest CT there, I think.
It shows the third rib fracture there, and
yep.
the old fracture.
Wonderful. So the report here, it should say, which of the two choices would you recommend?
Right, so it would be B, which says visual score of 0, heart to contralateral ratio 1.1, scan not suggestive, and incidental focal PYP uptake of third right rib interiorly. This finding may be due to trauma or neoplastic region, and recommend dedicated bone imaging.
Great. And case number 4. This is a 57-year-old asymptomatic female. She has a history of breast cancer and a double mastectomy, received chemo and XRT. She has a family history of ATTR cardiac amyloid in her father. He has a PHE64 LEU mutation. This is associated with both a mixed phenotype of cardiac and neuropathic involvement. Her echo is normal, cardiac biomarkers are negative, and she undergoes a scan, again, under this construct to try to see, does she have early cardiac involvement? Sabi, what do you think of these? Yep.
So it's important. If it's not that clear over here, we can't see clearly the anterior view, and you can't see the ribs. And on the lateral view also, we can't see that, because if you look closely, you can see these dark shadows in front, right over here, right? So these are the breast implants. So patients who have breast implants, we cannot do the visual score on those patients. We cannot do the heart to contralateral ratio on those patients. And sometimes patients who have dense breast, in those patients, I usually tell the technologists to make sure the patients are not wearing a bra, because if they're wearing a bra, that can interfere with the images also. So in those patients, you rely on your visual score on SPECT imaging.
Yep, and so she underwent a SPECT, which I think is shown here.
Yeah.
You want to tell everyone what it shows?
Right, on SPECT imaging, the line which you see coming from top to bottom, that's the sternum. You don't see any myocardial uptake, which is on the right of the sternum. Yeah, this is sternum, and there's no myocardial uptake on the right. So basically, it's a negative study.
Yeah, here is, I guess, is this a spot where the blood pool is occurring?
Right, it's very minimal. It's really nothing with, to call it.
Even blood pool,
yeah. Yes.
Good. So a negative scan in a woman who's an allele carrier, and maybe be rescanned in the future, but requiring SPECT imaging given the presence of the breast implants. And case number 5, interesting patient. He's 78 years old. He has a history of hypertension, hyperlipidemia, spinal stenosis, an EF of 50 with an increase in septal wall thickness. TTR gene testing was negative. coronaries are normal, serum-free light chains, UPEP and SPEP with immunofixation are normal, and the scan is shown below, in which you can see a visual score, I guess you'd say, Sabi, of about 1. Right? And HCL of 1.46. I don't know if you want to comment anything else about the scans, the question, what's the next best step?
Yeah, so I think here in the options, there's no SPECT. We didn't put the SPECT, but SPECT would be definitely one of the next step in this, because the visual score is 1 and to contralateral ratio is between 1.3 to 1.5. So these are the patients where you want to make sure it's not all blood pool. So SPECT, and if SPECT shows no blood pool and still the score is this, then the next step would be endomyocardial biopsy.
And I would say, since SPECT isn't a choice here, with a high clinical suspicion, this is the right age of wild-type TTR. There's no monoclonal proteins. Walls are thickened. If your clinical suspicion is high, no test is perfect. You could proceed on to an endomyocardial biopsy, especially if it will change clinical management. And on this scan, I think there was an incidental finding. You want to tell everyone, Sabi, on the lateral view what's represented here? Right.
So it's very common on PYP imaging that you're going to see uptake in the kidneys. And this one is incidental PYP uptake in the kidney, which is a normal, I would say, variance. But if you, in some of the cases, you might see some spleen uptake also, but this one is the kidney. And also you will see some of the patients, you see nephrolithiasis. So the kidney stones are going to light up.
Yep. I think we'll see that in a moment. So case number 6 is a gentleman, again, with a known PHE64LEU mutation, causes a mixed phenotype. He has bilateral carpal tunnel syndrome, had a previous right knee replacement. He has a nephrolithiasis, progressive lower extremity sensory motor neuropathy, highly consistent with transthyretin amyloidosis. And shown here are his the different views. Sabi, I don't know if you want to comment about the question is the HCL ratio and how it can be improved upon. His HCL ratio here is 1.3 and the visual score of 1.
Right. So over here, when we look at it, there's very minimal uptake in the myocardium on anterior view, and same on the lateral view, very minimal uptake. And the counts are a little off because of the renal stones. So what happens is the counts are there sharp, so all the other counts are a little down in the myocardium. But when we look at the heart to contralateral ratio, the regions which are drawn are off. If you look at the heart region, which is including the sternum, so that's going to affect the heart to contralateral ratio. So it should be moved towards the right so that it's away from the sternum. And when we look at the contralateral ROI, that's a little bit below the diaphragm. That's also going to affect the heart to contralateral ratio. So that has to be moved up a little bit. So the heart to contralateral ratio ROIs need to be redrawn.
Yeah, and you can see that, I think, shown here on the next slide, in which I guess they've been redrawn, as you said.
Yeah.
So moved away from the sternum and moved up above the diaphragm. And now, again, visual score is still of 1, but an HCL in the range that appears negative.
Negative.
And on this scan too, we saw on the lateral there was some incidental finding. I guess given his history of nephrolithiasis, I guess we'd all be pretty sure this is renal uptake again.
That's right.
Yeah, you can see here in the kidneys. Good. So these are just echocardiographic features of this patient. Here's his parasternal long axis and his apical 4, and I think you can see increase in wall thickness, valve thickening, and on echocardiography on apical 4 is increase in wall thickness with a preserved apical motion and impaired motion at the base. Increased intraatrial septal thickening. This is an echo that is strongly suspicious, if not diagnostic in this setting for cardiac involvement. So this particular patient, despite having a negative PYP scan, your suspicion for cardiac amyloid should be quite high. Here is his tissue Doppler showing a very low E velocity with an impaired relax pattern and a GLS that's highly suggestive of cardiac amyloid with apical preservation and a global longitudinal strain that's reduced. And so this finding occurs. It's a reason for quote unquote a false negative scan. So this individual has transthyretin cardiac amyloidosis. He just has a hereditary form of disease that's associated with, if you will, full-length fibrils. And that's been shown by the group in Sweden, in which they characterize fibril length. And when you have full-length fibrils with DBT, and presumably we assume PYP scintigraphy, there's no myocardial uptake, despite the fact that there can be a phenotype of cardiac amyloid, whereas a mixture of truncated fibrils, those are the ones that not only deposit in the heart, but also give a positivity to scintigraphy. And so this is a cause that's emerging of a false negative scan. This individual does have cardiac involvement, but his PYP scans are negative because he has only full-length TTR fibrils. And case number turn 2. I'll turn it over to you for this one.
Sure. So this is a 65-year-old male, hypertensive, hyperlipidemia, non-obstructive CAD, who had increasing shortness of breath, dyspnea on exertion. His transthoracic echo showed EF of 56% and intraventricular septum thickness of 1.5 centimeters. Had pericardial effusion, found to have ATTR cardiac amyloidosis by endomyocardial biopsy, and TTR gene sequencing is 59 lysine. Now, if in this interior view, we see that the uptake is minimal. Visual score is 1 on the lateral view, and heart to contralateral ratio is 1.31. So how should the report be worded? Visual score of 1, heart to contralateral ratio 1.31, and scan not suggestive of ATTR cardiac amyloidosis. Or B would be visual score of 1, heart to contralateral ratio 1.31, and scans not suggestive of ATTR cardiac amyloidosis, but may represent early cardiac disease in the context of high clinical suspicion. So this one would be B. There's a high clinical suspicion, and on top of that, the heart to contralateral ratio is in the gray area, and patient has a visual score of 1.
Yep. And we present these latter two cases not to confuse people, but to warn you that, again, no test is perfect, particularly in these somewhat unusual mutations we've observed that scintigraphy and its yield is not ideal. Having said all that, for the vast majority of folks that you'll encounter clinically with transthyretin amyloid in the United States, that is wild-type disease, followed by those who carry the Val122 ILE mutation or the Appalachian mutation, so-called THR60 ALA. Scintigraphy is a fantastic test when coupled with monoclonal proteins and has a high specificity. So I'll just summarize with some final pearls. Again, remember in PYP testing, the diagnosis is incomplete if you have only ordered a PYP scan and have not assessed for monoclonal proteins. You can't order scintigraphy without assessments for monoclonal proteins. Grading, as Dr. Bukhari showed today, has both a visual score and a semi-quantitative score, but to do the latter, you have to have appropriate placement of your regions of interest. Again, mild diffuse uptake could be false negative or early disease, and SPECT imaging can play an essential role in distinguishing especially a blood pool from a myocardial retention and a true positive. Never forget to be a clinician, interpret the scans in the clinical context, and remember, given the severity of this condition and if missed, and the fact that emerging drug therapies are most useful if given earlier, you should have a high clinical index of suspicion, and a myocardial biopsy would not be inappropriate in certain circumstances, despite the results on scans. And while uncommon, we heard about 5% of the time, a rib uptake, kidney and splenic uptake can occur in individuals with PYP imaging, and those should be interpreted appropriately and further testing as required clinically. Again, the false positive PYP scans, most importantly, AlAmyloid. So if you have evidence of a monoclonal protein, you cannot rely on scintigraphy. You need to do a biopsy, typically of the involved organ. blood pool is the second most common, or maybe the most common, along with AlAmyloid. And then there are reasons for focal uptake. We talked about, including an high rib fracture, metastases, and forms of cardiac amyloid that are not TTR can cause positive scans, as well as hydroxychloroquine toxicity. And the citations for those are noted here. And then again, false negative scans can occur in the setting of early disease. We saw a case of breast implant, not see a case of a pericardial or pleural effusion, but both of those can obscure and certain, penetrance, if you will, the isotope and certain mutations, as well as forgetting to image quickly. Again, as Dr. Bukhari, for example, HCl ratio that is promulgated in the literature of 1.5 is dependent upon imaging an hour after injection of the isotope in incubation. If it's delayed for any reason, you need to use a lower cut point. And if you don't use a lower cut point, you might conclude the test is falsely negative when it's actually positive. And again, SPECT imaging can play an important role in this particular clinical context. So I'd like to thank Dr. Bukhari for participating in the webinar today with me. Here are shown some supplemental materials. We strongly endorse the American Society of Nuclear Cardiology practice points, which are available on the web by Googling them. And then there are several articles that we've cited in the various literature today describing the utility and standard performance of testing. Please feel free in the future to reach out, and we are grateful to the Amyloid Research Consortium for sponsoring this webinar, hopefully improving the diagnosis for patients early, and look forward to future collaborations. Thanks.
Thank you.